Dr. Roger Stark is a retired cardiac surgeon and a healthcare policy analyst at the Washington Policy Center, one of the largest state-based think tanks in the country. He is the author of numerous healthcare studies, including The Impact of Federal Healthcare Reform on Washington State and the book The Patient-Centered Solution. We join him here on March 13, 2013, speaking on the Affordable Care Act, also known as Obamacare.
We are a nonpartisan, free market-based think tank that is essentially state-based. We have 6 different divisions. Healthcare is simply one of those. And as I was mentioning to some of you folks, obviously a lot of healthcare, almost 85%, 90% of healthcare comes from Washington, D.C. So I look at both state and federal policy, whereas our other divisions, like the economy, like the environment, like transportation, they deal with pretty much state and local type issues. It was the famous comedian Will Rogers who once said, I don't make political jokes. I just watch the government and report the facts. And so that's basically what we do at the Washington Policy Center. We just report the facts. And on your table are copies of the impact study that Mary mentioned. We did this about 1.5 years, 2 years ago, because we thought it was important that citizens of Washington State know what they were in for. Now, having said that, this is very detailed. It goes over a lot of what is going to happen to the citizens of our state. But a lot of this hasn't come true, or a lot of this has changed already in just the last 3 years. The basics are all in there, and the basics are still true, and fundamentally they're very accurate. So please take these copies, check it out, pass it out to your family and your friends. Also on the table are cards. We are not only nonpartisan, we are financially supported by individual donors. And the card on your table is a membership for a 6-month free trial. You'll get all of our announcements, all of our publications, and so forth, access to all of our work. At the end of the 6 months, if you like what you see, you can sign up. We'll send you an envelope. You can donate. If you don't, you can part friends. But anyway, please take this, fill it out, put a stamp on it, mail it in, or just hand it to me. And lastly, as Mary mentioned, what we're going to talk about today is the Patient Protection and Affordable Care Act, which is 2 of the biggest misnomers in the policy world today. It's not going to protect patients, and it's in no way going to be affordable, but that's what we're going to discuss. We are not going to talk about how we got to this problem, and we are not going to talk about what we see as patient-centered solutions to the healthcare problem we have. However, I did bring copies of my book, which are available here to you this afternoon. And we're pretty pleased with this book. It's been endorsed by a number of leading figures. Rob McKenna, when he was Attorney General. Nationally, former Florida Governor Jeb Bush has endorsed it. Representatives Nethercutt and Kathy McMorris Rogers have endorsed the book. And these are available for sale afterwards if you just see me and we can make the arrangements. $9.95, or actually this afternoon $10, and I'll pay instant state sales tax. So what we're going to do this afternoon is discuss the Affordable Care Act, or as the President now likes to call it, Obamacare. And the piece of legislation is huge, it's cumbersome, we can't go over all the details, but there are 3 things that I'd really like to do this afternoon. The first thing is I'd like to give you a little bit of background about the law, about the legislation, how it was passed. And the second thing I want to do is tell you fundamentally what are the basics of the law, what is actually in the law. And then the third thing, we now have had almost 3 years. March 23rd, 2010 was when it was signed into law. So we've almost had 3 years of experience with the law, and I'll bring you up to date on where we stand today. So those are the 3 things we want to do. So first of all, join me in my time capsule, and let's go back to late 2008, early 2009. And I think probably virtually everyone in this room, I know myself, we still have scars, if not open wounds, of the worst recession that this country has seen since the Great Depression of the 1930s. And that's where the country was in 2008. The American citizenry were polled, and they said, what are the most important issues for you and your family today, early 2009? Over 80% of the American public said, we are concerned about the economy, we are concerned about jobs in this country. 10% of the American public said, we are concerned about health care. So what did our elected officials in Washington, D.C. do for the entire year of 2009? They debated health care. And ultimately, in the beginning of 2010, they passed the Affordable Care Act, and it was signed into law, like I mentioned, in March of 2010. This is the most unusual piece of legislation that's ever been signed into law in this country. And I say that for a couple of reasons. First of all, it's one of the biggest pieces of legislation. It runs to 2,700 pages with all the amendments and so forth. And the other thing that you may have forgotten, it passed along strict party lines. There were no Republicans in either the Senate or the House who voted for this legislation. And there were actually Democrats in the House who voted against it. There were no Democrats in the Senate who voted against it. Now, let me put this in perspective for you. When Medicare and Medicaid were signed into law in 1965, those are the two big existing government programs that we've had for almost 50 years, they passed with support of both Republican and Democratic parties, signed into law by President Johnson, who was obviously a Democrat. But they had support of both major parties in this country, and that entire piece of legislation was 137 pages. So it gives you an idea of the complexity and the difference between this animal that we're dealing with here, the Affordable Care Act. Now, there are a couple other things you need to understand about the law, just as a fundamental. Basically, the cost, and the cost, it doesn't matter whether you're a Democrat or Republican, liberal, conservative. Everyone in this country can agree that the rising cost of health care is the most critical problem we have. And so, what was the cost of the Affordable Care Act? Well, the Congressional Budget Office, or CBO, they're sort of the scorekeepers in Washington, D.C. They look at any legislation that's being proposed by Congress, and they put a price tag on it. Now, what the CBO does is they look for the first 10 years of the legislation, and that's it. They only look 10 years out, and they think that's their job, and that's the way they do it. So our elected officials in 2009 voted on a number of $940 billion over those first 10 years. That was going to be the cost of the Affordable Care Act. And the CBO estimated that it was going to decrease our deficit and our debt by $100 billion over that first 10 years. Okay, so those are the numbers. Now, what you need to understand is the legislation, the taxes, the revenue, they started in 2010. And so the CBO looked at 10 years of revenue coming in to pay for the Affordable Care Act. The outgo of money starts next year in 2014. So there are 10 years of revenue and 6 years of outlay of that revenue, 6 years of benefits, if you will. So many of us in the policy world, we said, well, wait a minute, okay, that's the first 10 years. So even if you buy those numbers, what happens in the second 10 years? When you have 10 years of revenue coming in, but you have a full 10 years of benefits going out. And many of us were very concerned, and estimates at the time the legislation was passed were estimating that $2 to $3 trillion was going to be the cost for that second 10-year period. And we'll get into that in just a little bit when we look at where we are now after 3 years. So again, as background, that gives you an idea. And remember that this legislation now basically will control our entire healthcare system, which is fully 17% of our economy. So 17%, 1/6 of our economy is being controlled by this legislation. And no Republican voted for it. So keep that in mind. That's background. Okay, so the second thing we want to do this afternoon then is what is in the legislation actually. And 2,700 pages, we could be here through Memorial Day and the 4th of July if we're going to talk about every little detail. But there are some fundamentals, and it becomes actually pretty easy to understand when you look at the fundamentals that are in the law. First of all, one of the biggest things in this law is the individual mandate. And what the individual mandate says is that every adult over the age of 18 must purchase health insurance or pay a fine or a penalty or what the Supreme Court is now calling a tax. Now, that has never ever been done in the history of this country. This is totally unique. And you can say, well, right, Stark, but I drive a car and I have to have insurance to drive my car. And yeah, that's true. But that is a state law, and to be a citizen of Washington State, you do not need to own and drive an automobile. You can take the bus, you can ride your bicycle, you can still be a citizen of the state. This is totally different. This is a federal law, and it says if you don't have, you must have health insurance if you want to be a citizen of the United States. This opens a door, and this door has never been opened in the history of this country. And I've got very conservative friends that say, well, what if we passed a law, and actually there's a town in Texas that's about to do this. What if we passed a law that said to be a citizen of the United States, you have to own a handgun? Now, people in this room, you guys are laughing. The left thinks I'm crazy when I say that. But that is, once that door is open, folks, that is exactly where we stand. The federal government can tell us that we must purchase a private product to be a citizen. And whether you believe it's constitutional or not, the Supreme Court, in a very, very unique and kind of creative decision this summer said, well, we don't know if it's constitutional or not, but if you don't have insurance, that penalty, we're going to call it a tax, and Congress can tax its citizens, so therefore it's all legal. And that was Justice Roberts' ruling on this, which is totally absurd. But anyway, that's where we stand today. So it's an individual mandate. If you don't have insurance, you will pay a fine ultimately of about $700 a year or 2.5% of your gross income, whichever is higher. So remember that number, $700 a year ultimately. That's what you will pay. So, okay, so that's the individual mandate. The second thing in the law that you need to understand is the employer mandate. And what the employer mandate says is, if you're an employer and you have 50 or more employees, then you must provide them with health benefits or pay a fine or a penalty or a tax, as the Supreme Court is now calling it, a tax. Okay, so what is that tax? Well, if you don't provide health benefits at all, the tax is $2,000 per employee per year. If you do provide benefits and you have employees who opt out, then you pay $3,000 per year per employee that opts out. So it's either $2,000 or $3,000. Okay. So those are interesting numbers, but the critical number here, folks, is if you talk to Regents or Primera, two of our biggest carriers in the state of Washington, they will tell you that for the average family of 4, an employer paid last year about $12,000 per employee. Okay, so you don't have to be a math major. You don't even have to know algebra to know that $2,000 or $3,000 is a lot less than $12,000. So an intended or unintended consequence of this entire legislation is employers are going to look at that, they're going to look at their bottom line, and they're going to say, whoa, I can pay $2,000 or $12,000. And I'm thinking that $2,000 is a better deal than the $12,000. And that's what we're already seeing happening in this country. And again, we'll get into some numbers here later on. But again, that's intended or unintended consequence. So we've got the individual mandate, we have the employer mandate, and then the third thing are the insurance mandates. And there are a lot of insurance regulations, mandates in this law. Actually, there are some people who believe the entire piece of legislation is nothing but insurance reform. And you can sort of make a case for that kind of in a generic sort of way. There are 2 insurance mandates that you need to be aware of and you need to understand. The first is called community rating. And what community rating means is that everyone goes into the same risk pool. So if you're young, old, if you're healthy, if you're sick, everyone pays about the same for their insurance premiums per year. There are some modifiers, but those modifiers really kind of trap insurance companies into offering the same amount of insurance for about the same price. That's called community rating. And then the second mandate, insurance mandate, is called guaranteed issue, or you may know of that as a pre-existing condition. And what that says is that regardless of how ill an individual is or how injured an individual is, the private insurance company, health insurance company, must sell that individual a health insurance policy. That's guaranteed issue. Now, we tried this in the state of Washington back in the early 90s, and there was a really interesting case. It was in the Seattle Times and so forth, where a lady did not have health insurance, became pregnant, signed up for, I think it was Primera, delivered a healthy baby, canceled her insurance, and then sent the CEO of Primera a really nice letter that said, I loved your insurance, it was really great, I did well by me, and if I ever become pregnant again, I'm going to sign up for Primera insurance. So, the analogy that we like to use is homeowners insurance, right? I mean, what this guaranteed issue says is, you don't have to have homeowners insurance. Well, you have to pay a little tax or a little fine, but you don't have to have it. And if your house catches on fire, then State Farm has to sell you a homeowner's insurance policy while your house is burning down. Now that's crazy, right? But that's exactly what guaranteed issue is. So the problem that insurance companies have, like them or hate them, the problem that insurance companies have is they have no idea how they're going to mitigate risk and how they're going to plan for risk with community rating and guaranteed issue. And so what we are already seeing is our insurance premiums going up as health insurance companies, Primera, Regents, even group health to a certain extent, how they are anticipating these insurance mandates that are going to be imposed in 2014. So that fundamentally is the law. That is what the whole law is based on. Individual mandate, the employer mandate, and the insurance mandates. Now, the $940 billion, where is that money going to go? And if you look at the original budget, the money goes basically to two places. After you take out 4 or 5% for administrative costs, the 160 new agencies or expanded agencies, the IRS, everybody gets a cut of that. After the administrative costs, it goes to two places. It goes to an expansion of Medicaid, and it goes to subsidies, federal taxpayer subsidies, so people can purchase health insurance in the state exchanges. Okay, let's look at those individually. Medicaid. You may have heard the term, you may not know what Medicaid is. Medicaid began in 1965. It was part of the Medicare-Medicaid bill. Medicaid originally was a safety net insurance policy for kids of poor families. And when Congress passed it, they set it up such that the funding for Medicaid would be 50% from state taxpayers, 50% from federal taxpayers. And what Congress said was, well, this program is never going to grow because state legislators are not going to want to put more money into it. They're not going to want to sacrifice their state taxpayers. And what state legislators said was, wow, this is neat. We put $1 in for Medicaid, we get a matching dollar from Washington, D.C. This is not like education, right, or transportation. You spend $1 for education in the state of Washington, you get $1 worth of education. You spend $1 for Medicaid, you get $2 because of that matching dollar from Washington, D.C. So instead of a small, confined safety net program, what has happened is Medicaid over the years, since 1965, has grown into an unrecognizable, bankrupt program. In 1975, 10% of the country was in Medicaid. Last year, 20% of the country had Medicaid as their insurance plan. And you might think, well, yeah, Stark, but look, these people have health insurance, right? Yeah. Except that Medicaid, like I say, is a bankrupt, top-heavy, horribly bureaucratically run health insurance plan. And the people that get pinched in the financials of Medicaid are the providers, the doctors and hospitals. Medicaid pays doctors about 40% of what private insurance pays. Doctors cannot pay their overhead, keep their doors open with what Medicaid reimburses. So with the Affordable Care Act, what is going to happen is Medicaid is going to be expanded. And the federal government, the proponents of the Affordable Care Act, they basically bribed state governments. And they said, okay, instead of that 50-50 split, what we're going to do is we're going to give you 100% money for 3 years, and then gradually back that down to 90% federal money, 10% state money after 6 years. So we've got our governor running around saying, hey, this is free money. We can't leave money sitting on the table. This is free money from Washington, D.C. Now, a couple things that are wrong with that. The first thing is federal taxpayers or state taxpayers. We're all in this together. It's not that there's a huge pile of Medicaid money in Washington, D.C. and it's going to go to Texas or Pennsylvania or California if we don't take Medicaid. No. Everyone in this country is going to see increase in taxes and more regulatory burden because of expanding Medicaid. And what the Affordable Care Act does is it's going to add about 16 to 20 million more people into this already bankrupt program of Medicaid, where our existing Medicaid patients have a very difficult time accessing health care simply because providers can't pay their overhead, and hospitals to a certain extent can't pay their overhead with what Medicaid reimburses. And about $400 billion of the Affordable Care Act budget was set aside for this Medicaid expansion. Okay, so the second place money goes is into the state exchanges. And so you're sitting there saying, what's a state exchange? Conceptually, it will function as an insurance brokerage or a clearinghouse, so that people, individuals, and small group employers can go into this state exchange and they can find insurance policies for themselves, for their families, and for their employees. So where's the money coming? Well, if you make up to 400% of the federal poverty level, you qualify for taxpayer subsidies to help you purchase insurance plans in these state exchanges. So they say, fair enough, what's 400% of the federal poverty level? Last year for a family of 4, it was $92,000. So we're not talking about a safety net program here, folks. We're talking about the government controlling not only poor individuals, but also straight up to the middle and upper middle class economically. And that's the state exchange, and that's how the money is going to function through there. Now, that $96,000 is tagged to inflation and the cost of living, so that by the year 2016, a family of 4 making $96,000 will qualify for subsidies in the state exchanges. So that's where the money goes. It goes to those two places: expansion of Medicaid, 16 to 20 million more individuals, and to subsidies in the state exchanges. A fair question is how many individuals are going to go into the state exchanges? And that's like the $64 bazillion question, and no one knows. But we've had to change our adjustments on what this thing is going to cost based on new numbers that we're getting over the last 12 to 18 months. So, okay, so that's where the money goes. Where does the money come from? Remember, $940 billion. Again, if you look at the original budget that the CEO looked at in 2009, the money comes from two sources. It comes from a cut to Medicare, and it comes from increasing or new taxes. Okay, so what's Medicare? Probably most of you are familiar with Medicare, or at least what the term is. Again, Medicare passed with Medicaid in 1965. It's our government-run health insurance for seniors. If you're 65 years of age or over, Medicare is your main insurance, unless you have a grandfathered pension, work-related insurance plan. Medicare, when it began, looked like it was going to be a great program. The problem is, like any other government bureaucratic program, it has expanded wildly. By 1990, Medicare was 7 times over budget. Medicare today has an unfunded liability of about $45 trillion. Now, trillion, that's with a T, $trillion. That's about 4 times the output, the economic output of the United States last year. Medicare is bankrupt. Medicare absolutely, positively needs to be reformed. There's absolutely no question about it. But it needs to be reformed with a scalpel and not a chainsaw. And what Obamacare does is it takes $500 billion right out of the Medicare program. And most of that is on the provider side. Hospitals, nursing homes, ambulance service, doctors. And our Medicare patients today are having the same problem that Medicaid patients do, simply because Medicare pays about 70% of what private insurance does. And more of our physicians, especially family practice, internal medicine, primary care, are having a very difficult time paying their overhead with what Medicare reimburses. And we're seeing fewer doctors accept new Medicare patients or limit the number of Medicare patients they're taking. And what the Affordable Care Act does is it just, again, with a chainsaw, it cuts $500 billion more out of this already bankrupt program. So that's where half the money comes from. The other half comes from new taxes or existing taxes. There will be taxes on insurance premiums, health insurance premiums. There will be taxes on health insurance companies. There will be taxes on medical device manufacturers, on drug companies. And these taxes will either be taken out of their research and development, which I hope not, or they will be passed on to consumers. And everyone in this country is a consumer of healthcare, so we're all going to see costs go up. This is not going to just be a tax for the rich, or on the rich. But the rich were not excluded. And also I should add that everything we're talking about financially today has nothing to do with the fiscal cliff debate, has nothing to do with the debate that's going on in Washington, D.C. now. What we're talking about is baked into the law. This is part of the Affordable Care Act. So there will be new taxes on the rich. There will be 0.9, almost a 1% increase in payroll tax. No big deal there. We've seen increase in payroll Medicare taxes since 1965. So that's that, and we can deal with that. There is a new kind of unique tax, 3.8% that the rich are going to have to pay on unearned income. So what's unearned income? Well, it's like dividends, capital gains, rental property, in certain cases, capital gains on the sale of homes. 3.8% on top of whatever income tax they're paying, on top of the increase in the payroll taxes. So who are the rich? Well, they're defined as any individual who makes more than $200,000 a year, or a couple who makes more than $250,000 a year. Okay? Now remember those subsidies and the state exchanges were tagged to inflation and the cost of living? The definition of the rich is not. So it's $200,000 a year forever, which means that these new taxes are going to function just like the alternative minimum tax. As we see more inflation, as salaries go up, as people earn more money, there are going to be more and more American citizens who are going to be called rich, who are going to be in that $200,000 category, and who are going to pay all these increased taxes. So, thumbnail sketch, that gives you kind of a picture of how we got here and what is in the law. As I say, it's 2,700 pages. There are a whole bunch of details in there, but those are the fundamentals. So the third thing we wanted to talk about is where we stand today, 3 years later. And we've all had at least 3 years to think about this law. And I know many of you out there have probably formed your own opinions about what you think, talking it over with your family, with your friends, and so on. As Mary mentioned, I'm a retired surgeon. As a group, surgeons, essentially, we just wanted to wash our hands of this entire piece of legislation. Except for the plastic surgeons, who wanted to put a new face on it. And then there were the dermatologists, the skin doctors. They didn't want Congress to do anything rash when they were debating. Although, my friends, the anesthesiologists, they thought the whole thing was a gas. But the psychiatrists, they thought it was simply madness. And then finally, the obstetricians, the baby doctors, they thought during the debate, they thought that Congress was simply laboring under a misconception. So anyway, so that's the take. So, okay, so we're 3 years into this. Where do we stand? And you can look at it in a number of different ways, but the way I think kind of brings it all home is what was the American public told during the debate in 2009? Well, the first thing we were told is this legislation is going to bend the cost curve of health care down. And remember, everyone in this country understands that the rising cost of health care is the problem that we have. So the CBO now has had 3 more years to look at this. And their new total estimate over the next 10 years is not $940 billion, it is now $2 trillion. Now, the CBO still believes that it's going to decrease our deficit and our debt by $100 billion. But what they're now projecting, instead of that $500 billion cut to Medicare, they are projecting a $716 billion cut to Medicare. And the difference, the $1.3 trillion difference, is going to be made up by new increased taxes. And so those are the new numbers. The chief medical actuary in Washington, D.C., he retired just a couple months ago, a fellow named Richard Foster. He looked at this about a year ago, and he said, okay, we spent 17% of our economy, of our gross domestic product, in 2009 on health care. With the Affordable Care Act in place, by the year 2020, we will be spending 21% of our GDP, 21% of our economy on health care. In no way is this going to bring the cost curve of health care down in this country. The second thing the American public, we were told, this is going to provide universal health insurance coverage. And it's not. A number of groups, both on the right and the left, have looked at this. And when the debate started, there were about 50 million uninsured people in the United States. For one reason or another, they didn't have health insurance. The Affordable Care Act will provide insurance for 30 to 32 million, leaving about 40% of the uninsured without health insurance. So in no way will this provide universal coverage at a cost of, remember, $2 trillion. If you like your present insurance, you will be able to keep it. And again, you don't have to be a math major to figure out that $2,000 is a lot less than $12,000 for employers. And last April, almost a year ago, one of the largest polling companies in this country, it's called the McKinsey organization, they polled thousands of employers. And what they found that 30% of small employers were planning to drop their employee health benefits. And here's kind of a surprising number. 10% of large employers were planning to drop health benefits. Now think about that a minute. That means potentially that large companies like PACCAR, like Microsoft, like Boeing, like Amazon, they're looking at their bottom line, and their chief financial officer is saying, hey, you know, if we want to be competitive nationally and internationally, here's a great way to save us a bunch of money. And so what we're going to see, the tip of the iceberg number out there now is about 14 million people are going to lose their insurance or need to change their insurance. Just as an aside, for example, that cut to Medicare, we're projecting that about 7.5 million seniors who have Medicare Advantage or Medicare Part C will probably lose that and be forced to go back into traditional Medicare Part A, Medicare Part B. So that gives you kind of an idea of what we're seeing in this country and what we're facing. We were also told, the American public was also told, that it is going to eliminate, the Affordable Care Act is going to eliminate waste, fraud, and abuse in our healthcare system. Now, in our existing Medicare and Medicaid programs, again, we've had over 45 years experience with them, at least 10% of the cost in those programs, and by some estimates up to 25 to 30% of the cost in those programs, goes to waste, fraud, and abuse. And we were just talking about that this morning, the fraud and fraudulent Medicare kinds of things. There is nothing in the Affordable Care Act to eliminate, decrease waste, fraud, and abuse in any of these government programs. And then the last thing the American public was told during the debate is this is going to improve the quality of health care in this country. And I will admit there's some language in the Affordable Care Act that deals with quality and quality markers and so forth. But if we're seeing our Medicaid patients and our Medicare patients having a much more difficult time accessing health care, in no way is that going to improve the quality of health care in this country. And so we see that as being a sham and that as being a false argument as well. So that's where we stand today. We were discussing this earlier as people were registering and so forth. If I had a crystal ball, what do I think ultimately is going to happen? And some of this is just my hope that I'm projecting on you folks here. But I think the program as it exists now, the Affordable Care Act, is unsustainable. We can't afford it. It's too cumbersome. It's too big a regulatory burden. It is either going to be crushed under its own weight, or people are going to start listening to individuals like Paul Ryan, who has a plan for Medicare, who wants to repeal the Affordable Care Act. People are going to start listening to individuals like Representative Ryan, and they're going to see the light, and they're going to come around here. And again, that may be my projection, but stay tuned. So let's open it up for questions. I think we have some time. Your question is an excellent one. Like I say, up to about 2 weeks ago, there were 1,300 waivers that have already been granted. So, yeah, and most of them are going, many of them are going to unions and things like that. Is there something in the law that's going to force providers to accept Medicaid and Medicare? And the answer is no, but I will tell you that the blueprint for the Affordable Care Act is Romney Care. Massachusetts has been dealing with this since 2006, and their legislators are floating that now, and people back in DC are talking about that. And she's asking about TRICARE, which is the military version of health insurance run through the Medicare program. Originally, that was absolutely off limits. Over the last 6 to 8 months, people are talking about cutting back on TRICARE as well, kind of lumping it into the Medicare program. So I can't tell you more than that right now, so you just have to watch and wait. That's a great question, yeah. Well, right now we're not seeing a decrease in applications to medical school. Will we in the future? Conceivably. I mean, if being a doctor is like working for the motor vehicle department, yeah, we definitely are going to see a decrease. We're going to see a change, though, in the delivery of health care. And what I mean by that is, even in the Puget Sound area, but certainly nationally, we're seeing doctors band together. We're seeing more and more hospitals band together. We're seeing more and more physicians becoming employees of hospitals. And what many of us are predicting is, instead of having your doc who works 24/7, who has his own office and so forth, what we're going to see is physicians, nurse practitioners, physicians' assistants as shift workers, basically. Whether it's 8 to 5 or 7 to 7 or something like that, and they're going to work shifts in that kind of a fashion. You may or may not know who your doctor is going to be from any one given time, and I think we're going to see a sort of a change in how healthcare is delivered, and that's inevitable. Some of the paying schemes, the reimbursement models in the Affordable Care Act almost require that. Doctors and hospitals are going to have to form some kind of a financial relationship. The easiest way is for docs to be employed by hospitals, so it's kind of pushing things in that direction. Well, that's a $64,000 question. Healthcare is going to have to be rationed somehow, and it may be rationed. One of the things that was in the law that raised a lot of controversy was this thing that was called the death panel, and it's the official term is the Independent Payment and Advisory Board. And what they were going to do was they were going to look at, quote, best practices and figure out what people need. Operations, drugs, things like that. And cost could not factor in there. But I can guarantee you this committee is sitting in a room and they've got total hip replacement, age brackets, cost of total hip replacements, and that's going to be a factor. Yeah, you raise a good point, and I will tell you, as a retired physician, we have other retired physicians in the room here. We hope not. I mean, we truly hope not. People, I firmly believe that individuals are still going to go into healthcare to take care of sick people, and they're going to do the best job they possibly can with the resources that they have. So, well, let me be real clear about the first thing you said, and that is that there are no taxes on people unless you're rich. No, those taxes on insurance companies, insurance premiums, drug companies, those are all going to be passed on. There's even a crazy 10% federal sales tax on tanning salons, for example. Well, that started right away. That started in 2010. Why tanning salons, you might ask? And I'm convinced it's because they didn't have a good lobbyist sitting at the table. And so they, the music stopped and they didn't have a chair, I think. No, we're all going to feel the taxation here. She asked, how is this going to affect alternative medicine, like naturopaths and midwives and things like that? And I really don't know. But I will say what we're going to see, at least in the interim here, is we are going to see Medicare, Medicaid, Affordable Care Act over here, government bureaucracy, and then over here we're going to see cash and carry free market kinds of things, kinds of solutions, walk-in clinics, maybe more use of alternative medicines and so forth on a pay-as-you-go sort of basis. So I think it's going to be sort of a stay tuned kind of thing, and we'll just have to see how this plays out. Yeah, the question is, if a patient got health care outside the Medicare system, would that patient be penalized? And the answer is no. The patient would not be, but the doctor would be. And if you balance bill or you accept payment above and beyond what Medicare gives you, then you sort of opt yourself out of Medicare for at least 2 years. So what what docs are doing now is they're opting out of Medicare completely. And they're setting up concierge practices or one thing or another like that. And you may have heard that expression, concierge, and it's associated with the very rich having their private doc, paying cash and things like that. No, that's one model. But we have a model in Seattle right now. It's a group of family practice docs, and they charge, it's $60 or $69 a month for poor individuals to get 24/7 primary care through them. And they have over 800 patients in their practice now, and financially this makes sense for them. So again, that's sort of a creative, free market, cash and carry way of handling healthcare. And so, like I say, I think we're going to see more and more of these things crop up as we go. In no way is this law humanitarian. In no way is this law fair. Those are words that the left loves to use. If you want to be fair, if you want to be humanitarian, what you do is you allow the patient to make their own decisions about their health care and control their own health care dollars. That's humanitarian. So the issue is lifetime caps, and what they are is literally they put a cap on how much money the insurance company will pay over the lifetime of a claimant or an individual. It turns out, this is really an interesting point, if you talk to the insurance companies, they will say, yeah, lifetime caps, no, okay, but we can deal with that. So that is not a big issue for them. I was shocked when they told me that. But the community rating and certainly the guaranteed issue, those are huge issues for them. Yeah. That's a good question. And the really poor, if you make less than 133% of the federal poverty level, Medicaid will be your insurance. And so this will be provided by taxpayers. So you won't have any out-of-pocket. You may have a little, dollar here, dollar there kind of thing. But Medicaid will be your program. So what we're going to do is we're going to take 16 million poor and put them into this program that's already terrible insurance, that's already bankrupt. Yeah, that's a good question. She says it looks like the entire point of Obamacare is to eliminate private insurance. And I would go so far as to say the architects of this, the Barney Franks, Nancy Pelosi's of the world, and so forth, their end goal is a single payer system. And actually, a number of them are on record during the debate saying, this is the first step, we'll get there. Well, that's a great question, and I can't give you all the details and all the specifics, but I will say if you're 65 or over, you really have no other choice unless you have a job-related retirement plan. So Medicare is really the only insurance that you will be able to get for major medical and so forth. Medicare is broken into 4 parts. Part A covers hospitalization. Part B covers physicians. Part C is Medicare Advantage, which is, it's like competing private insurance networks against each other. And then Part D is the supplement for drug benefits. I will say Medicare has a ton of paperwork, and it's probably behooves everyone to go through that to figure out what's the best for your situation, your family situation. And I can't and wouldn't want to try and stand up here and tell you what's best for your situation. But understand this, that's the only insurance you have available. Yeah, the co-pays, deductibles, you can get it through AARP, you can get it through Primera, so forth. But your major medical is through Medicaid. You're absolutely correct. There were 17 major individual small group insurance companies, health insurance companies in the state. We now have 3. And we lost something like 14 or 15 as soon as that legislation was passed. What many of us see happening is insurance companies, to keep their heads above water, are going to increase premiums. And then the government is going to say, wait a minute, we're going to put a cap on how much you can charge for premiums, but we're still going to tell you what benefits you have to put in your packages. And remember, each of those benefits costs money. And I think what, at the end of the day, maybe not next year, maybe not 2016, but certainly in the next few years, we're going to see private insurance companies essentially become public utilities, where their pricing and their benefits will be set by the government. They'll be passed through, money passed through their hands to go to providers, and that's how they're going to keep the doors open. They will not be private entity insurance companies like we see today. One more question, and then we'll wrap it up. Yes, ma'am. Well, that's the question. You put your finger right on it. And what you have to say is, all right, cost, everyone agrees the rising cost is the problem we have with healthcare. Then you have to ask yourself, what is driving that cost? And this may be the most important thing I tell you this afternoon. The thing that's driving our healthcare cost is the fact that someone else, a third party, is paying for our healthcare. Whether it's our employers, or whether it's the state government, or whether it's the federal government, somebody else is paying for our health care. Now, we could debate all afternoon whether health care is a right, and I don't want to get into that debate. But we can all agree that health care is a necessity of life, just like food, shelter, clothing. Now, think about that for a minute. There's no third party paying for our food. I know I'd be a little bit different if somebody was. Nobody's paying for our clothes. Hard for me to imagine, but my wife would probably have a much bigger clothes closet than she does now, if somebody else was. And shelter. You know, we'd all be living on waterfront mansions if somebody else was paying for our shelter. Those are necessities of life. And that's the model, the economic model we have in healthcare. So what's the solution? The solution is to give those healthcare dollars to individuals and let them figure out what best healthcare is for them and their families. And that's kind of the short 25-word solution. And if you want more solutions, great segue. If you want more solutions, here's the answer. Thanks very much, guys.
Dr. Roger Stark is a retired cardiac surgeon and a healthcare policy analyst at the Washington Policy Center, one of the largest state-based think tanks in the country. He is the author of numerous healthcare studies, including The Impact of Federal Healthcare Reform on Washington State and the book the patient-centered solution. He delivered the preceding address on the Affordable Care Act, also known as Obamacare, on March 13, 2013.